What do you suppose is? You looked ahead. Hypnea, not bradypnea, is the most common sign of hostile pulmonary embolism. Let me tell you something else they'll do. They will sit up in the bed and say, I'm dying. If a client ever sits up and clutches their chest and says they're dying, they're dying. And you act fast. You don't stop to get vital signs. You're pulling the plug out of the wall. And you're saying, I'm here with you. You're getting help. And you're getting the oxygen, and you're getting everything ready. Because that, why do you suppose they do that? Why do you suppose they go, I'm dying?
Pain.
For pain.
Can't breathe.
And the brain, before the body even knows that it can't breathe, the brain's going, where's my oxygen? And they get anxious. Okay? Extreme anxiety.
Because it's because you're feeling the LOC.
Your brain is knowing immediately that it's not getting the same amount of oxygen. Almost, it happens so fast. I mean, remember, brain death is in 4 to 6 minutes. So you throw an embolus, and before you even can register that you have pain, clients will often have anxiety and break out into a profuse sweat. And pain, it's just like, it's a simultaneous thing. Yes, Hope?
Okay, instead of saying you actually ask you specifics, what do you do if you're in an information of that?
You pull the plug out of the wall and you stay right. You use a nursing student?
Well, I think as a nurse. Like now I'm trying to take this and put it into nursing
Right.
practice.
You are calling for help. You are not leaving that patient.
Okay, so you said pull the plug out of the wall.
I mean the call light.
Oh, okay.
Pull the plug out of the wall.
It's happened by
It's
accident.
okay. We're just going to shut up. Okay, we're just going to pretend. We're going to pretend this event has not happened. And we're going to pull the plug out of the wall and stop. I'm so sorry. And you reassure the patient and you help them into a physiologic position if they're not in one. And you should always be, bless your hearts, you should always be checking to make sure. You know, when you go in your room as a nurse, are you making sure your emergency equipment's right there? Is that part of your environment of care? That should be part of your environment of care.
So what we can do is if we call someone, you then call the doctor, while you stay with the patient, and you just
And you're doing, yes, and well, Cobb and Kenston both have got, what are the teams called? They have teams that
Rapid response.
Rapid response team before you need a code. You'll probably end up with a code. You'll probably end up calling a code. So you're calling your rapid response team, and they're probably going to call a code. Because the pulmonary embolism is it's a true emergency. It's like, you have to act fast. You as the nursing student, or you as the nurse will have your individual policies that go along with wherever you're working. You as the nursing student, you call the emergency button. And that's not pressing the button. Pulling the call light, the emergency call light out of the wall, sends out all the alarms.
That's what I was going to ask. It sets off alarms.
Sets off alarms. It's not just it's not a light at the desk.
Okay.
It's setting off the alarm. Bang, bang, bang. That's the same thing. That's going to set off alarms. Okay. So that's what you're going to do. You're going to oxygenate. You're going to
See, this is what I'm asking. Like,
I got you. You're going to make sure she's oxygenated. But that's what I'm talking about emergency equipment. You're going to oxygenate. And you're going to have somebody preparing whatever emergency medications need to be given. And that's going to depend upon your patient and the situation. Yes, Mindy. The second was
Everybody else may already know this, but when you say call a code, do you mean like we as a nurse kind of stand back at that point and the rapid response team comes in and takes care of everything and
it will depend how involved you are in the code depends upon your institution.
So we can be right up there with the patient. Or is
Yeah.
rapid response kind of normal now, like that's everywhere?
Rapid response is in a lot of places.
Yeah.
It's one of the Joint Commission things that you're reducing. Because we recognize that by the time we call a code, if we look back on a patient that had a code, looking back we could see, well, if we paid attention to this or this or this and intervened back here, we might not have gotten to the point where we had an arrest.
And those are commonly ICU nurses?
You know, it depends on different institutions.
Okay.
Some places just use hospitalists and they use PAs, and some people use respiratory therapists, and some people use ICU nurses, and that's gonna depend on your institution.
Gotcha.
They called it on a, well, they were going to call it on a guy, but I was on the second floor that day, and it wasn't my nurse, but they sent me down there to watch. But there was a guy from respiratory already on the floor that is a part of that team, and there was a guy, happened to be there from cardiology, so the two of them went in, and they actually never set the alarms off or anything, and
They didn't have
I
to
got
because
to
they're
watch
right
him
there.
draw the blood out of the artery in the arm and work on it and everything, and they had me like a wallflower on the wall, and the nurse was out in the hall charting, she didn't,
She was
wasn't
taking care,
part
because
of it
they
at
were
all.
they were managing it, depends on where
There's
you are.
Ton
Depends
of
on
people in there.
where you are.
Keystone, they
Yeah.
say they try to do the emergency response team first before they call to the code. When they do call code, everybody comes.
Mm-hmm.
Floor gets overcrowded, nobody knows who can do anything.
Where was this?
Mm-hmm.
So nobody could do anything? What do you mean
Well,
nobody could?
that's why they try and call the emergency response team first. Because
Oh, yeah, absolutely, because with the code, it's just chaos.
Yes.
It's controlled chaos, but it's chaos, and everybody's involved. Yes, Elizabeth?
I'm not sure if this is just for an air ambulance, but I heard some, like, I remember reading somewhere about immediately throwing them into Millenberg and putting them on their left side.
I don't know about that.
That's what I heard.
I heard
that.
Too.
Yeah.
But I don't know if that's just for the air ambulance or if that's also for the like, blood clot. Granted, you wouldn't really know.
I don't know, who can find that out? Because I don't know.
Google. No, I read it in a textbook somewhere.
In our textbook?
Yeah,
I don't know which one.
I read it somewhere too.
Okay,
I
when
haven't
y'all
read it
find it,
yet.
let me know, because we need to talk about that, because, yeah, in terms of emergency positions. Well, the only way you're gonna get an air ambulance is, if you've pulled a line incorrectly.
It might have been in the section about the IVs.
IVs, yeah, if you pulled a line incorrectly. That's why you don't pull lines.
Dialysis nurse said the same thing because there's so many areas that a
Mm-hmm.
bubble could get in
Right,
when you're starting
Mhm.
things.
when you're accessing that fistula.
Mhm.
Let's talk about another one of my favorite words, pneumoconiosis. What in the world is that? Occupational lung disease, white lung disease, brown lung disease, black lung disease, asbestosis, okay? Secondhand smoke. Those can all be considered occupational lung diseases. If you're a bartender, you can end up with occupational